Hi, everyone, and welcome back to the third of 5 webinars on Medicare drug payment. I am Pedro Salomao with Definitive Health Partners.
And I'm John Warren from Gettysburg Healthcare Consulting. Welcome back.
And welcome, John. Let's dive right back into it. So the first two sessions, webinars, we looked at Medicare from the 4 parts, A, B, C, and D. This time around, we'll be looking at coverage, coding, and reimbursement, and how each of these lead into optimizing not only access, but the value of therapies in general. Now, John, when we talk about coverage, there are several types. Can you speak to these and how Medicare goes about determining coverage for these biologics or pharmaceuticals, and does this differ from what commercial plans do?
Sure, thanks, Pedro. There really are 3 types of coverage that the Medicare program is concerned with. The first are national coverage determinations, and these are coverage or sometimes non-coverage decisions that apply to all Medicare beneficiaries across the country, irrespective of where they live. This process to get a national coverage policy can take at least 9 months and sometimes longer. Second is the local coverage determination process. And again, this too is a coverage or a non-coverage decision, but it only applies to Medicare beneficiaries that are residing in one of 12 specific geographic jurisdictions. And local policies can vary from one jurisdiction to another. In fact, you could have a policy in one state and in the very next state have no policy at all or have a different policy. Regardless of that, these local policies can't override a national policy, but they can be more stringent in some cases. And unlike a national decision, there's no real regulatory timeline that the Medicare contractors have to work within, even though they strive to release their policies in a timely manner. We've seen timelines as short as a few months, and it's not unheard of to see local policies linger for several years. And then last but not least, in cases where there are no coverage policies, and this, by the way, is the vast majority of cases, claims are adjudicated on what's called an individual consideration basis. And that's where the Medicare contractors will look at an individual claim and make a decision based on the merits of that claim and sometimes on the merits of the medical record, whether or not the particular service that was provided should be covered and is reasonable and necessary for that patient under those specific circumstances.
Okay, so John, that makes sense. What information is most important when determining coverage determination? And I'm thinking clinical or economic.
Yeah, so basically for all 3 types of coverage decisions that we talked about, the primary lever for that decision-making process is going to be clinical information.
Okay.
There's a clear preference from both CMS and from the Medicare contractors for published literature that supports the validity, the utility, the safety of the particular technology. Now, the gold standard is always going to be a randomized clinical control trial showing the efficacy of an intervention. But in some cases, that's not necessarily the most realistic opportunity. Now, what Medicare and its contractors don't look at is health economics data. They don't look at things like the cost of a particular service or the savings that may be accrued from a particular service, at least not today. Perhaps in the future they will, but as of right today, they don't do that. And I do want to point out, too, that FDA coverage decisions, or I should say FDA approval decisions, are not the same as a Medicare coverage decision. Medicare has to make sure that there's a benefit category for the intervention. They want to make sure that the intervention is safe and effective in the Medicare population. And they want to make sure that that intervention is reasonable and necessary for treating that Medicare beneficiary's particular medical condition. And those 3 things are not always the same as what FDA looks at when it makes its decision whether or not an intervention is safe and effective.
Yeah, no, that makes sense, John. I'm thinking through. There's been a bit of activity around coverage for first-in-class therapies. Can you share what you know about CMS's approach since you worked there for so long and just granting coverage for these new technologies?
Yeah, so I think CMS recognizes that the coverage process doesn't always keep up with changes in technology, meaning that healthcare technology is advancing in some cases at such a rapid pace that the coverage process, just simply the way it's structured today, can't make timely enough decisions. A couple of years ago, Medicare proposed a Medicare coverage for innovative technologies policy, which was ultimately rescinded.
Mhm.
But they're now thinking about developing what's called the Transitional Coverage for Emerging Technologies policy. They're in the process of gathering stakeholder feedback about what that kind of a process would look like. But overall, I think what the agency is aiming to do is create a coverage process focused on emerging technologies that has a timeline that aligns with FDA approval to sort of minimize that time gap between when FDA approves an emerging technology and when Medicare covers it, and also allows for the gathering of additional clinical data supporting the use of the product, specifically in the Medicare population. So, really, they're aiming to get a more timely, interactive, and transparent process than what they have now.
Okay. Yeah, that makes sense. So, John, you mentioned national coverage, so I'm a bit curious if the product gets national coverage, and on the slides we can see Part A, B, and C and D. If you get national coverage, does that apply across all parts of Medicare?
Yeah, so keep in mind, Pedro, the first decision point in any coverage determination is whether or not the intervention has a benefit category. So, for instance, what CMS is going to do during that process is look at the new technology, whether, and no matter what it may be, and determine whether, or which, I should say, Medicare benefit category it falls under. So, for instance, if Medicare looks at a new technology and sees that it's an inpatient procedure, for instance, they will determine that that procedure should be covered and paid under Medicare Part A. By comparison, if they see a technology that's used in a physician's office, that technology would be covered and paid for under Medicare Part B. But when you compare that to Medicare Advantage plans, those plans have to actually cover everything that traditional Medicare covers, and they can go beyond that sort of standard benefit package, if you will. Now, the scope and the breadth of those additional benefits is really driven by how efficient and how prudently that plan behaves with its own resources. And then Part D plans are designed really to provide wraparound coverage for drugs that otherwise wouldn't be paid for by Medicare. Now, Medicare puts out lots of guidelines that those Part D plans have to adhere to. These are policies, for instance, that require them to cover at least two agents in many drug classes, or the policies that have established protected classes where Part D plans have to cover all of the agents in the class, and other rules about non discriminatory plan design. But really, within those overarching Medicare rules, those Part D plans have a good amount of leeway to decide exactly how they're going to structure their benefit plans from one year to the next.
Right. No, that makes sense. So moving on to coding, and the one thing companies need to keep in mind is that coding is distinct from coverage, right, of a new therapy or technology. So the assignment of a new code does not automatically imply coverage, um, you know, by any payer, in fact. So John, can you highlight the major code sets and what they classify medically?
Sure. So what we're showing on this slide, I should say, are five of the most commonly used code sets in the Medicare program. CPT codes are describing medical procedures. By comparison, HCPCS codes are also describing medical procedures, but those that aren't otherwise described by a CPT code, I should say. HCPCS codes also describe things like Part B covered drugs and diagnostic services, ambulance services. It's a wide range of procedures and services that are covered by HCPCS. ICD-10 CMS or ICD-10 CM codes describe diagnosis codes, describing the condition that the patient has, and ICD-10 PCS codes describe inpatient hospital procedures. And then finally, NDC codes, which are used primarily by the Part D program, are used to identify drugs by their individual labeler, the dosage, and the package sizes. Now, for newly covered items and services, CMS can choose to apply an existing code if there's one that describes the same or a similar service. They can choose to use a miscellaneous code or a not otherwise classified code, or in some cases, they can choose to create a new code for payment purposes. And that's really based on what the coding criteria says and how it's applied to the new technology. Now, for drugs in particular, and I know that's what we're talking about today, HCPCS codes are the usual code set. Most drugs are described by a HCPCS code, or at least the ones that are covered by Medicare Part B. And within that HCPCS code set, the primary decision point is whether or not the drug is a single source drug or biological. If it is, it's most likely going to be assigned its own unique HCPCS code that describes only that drug. Now, by comparison, if it's a multi-source drug, that is one that has generic competition, CMS will include all of the generic and all of the brand name reference drugs into the same HCPCS code. Now, Pedro, since the volume of healthcare claims that are processed on a daily basis is just phenomenal. I mean, Medicare alone is responsible for millions of claims a day. Having this kind of standardized coding system is really essential, not only for payers like Medicare and really any other health insurance program, but for providers as well. It provides a way to ensure that claims are processed in an orderly and in a consistent manner. But it's also important that these code sets stay current. ICD-10 and CPT are updated at least once a year. HCPCS codes are updated anywhere from 2 to 4 times a year. And the frequency of these updates is really an attempt to balance the desire to recognize new technologies, recognize new interventions through the coding system, with the need to provide a stable system that's predictable for businesses. So it's really important for providers and coders as well to stay educated and to stay prepared for upcoming changes to coding to make sure they're accurately utilizing those codes appropriately.
Yeah, no, that's a great point, John. From a manufacturing perspective, we've been asked, is there a specific order that we need to apply for when it comes to these codes? For example, a HCPCS or CPT code. The reality is it's just identifying what codes are going to be necessary for providers to get reimbursed. But John, I'm thinking about phase 2 trials or phase 3 trials and really understanding, if I'm a manufacturer, when should I be submitting for a new HCPCS code?
That's a great question, Pedro, and I know that you and I have had multiple conversations about this. And I really think the sweet spot to start having those discussions is anywhere between maybe 18 to 24 months before you're ready for launch. That's going to give manufacturers, even though it seems like a lot of time, it's going to give them the time that they need to work through not only identifying the existing coding environment, but whether or not existing codes exist, and start to think about planning for alternatives if the preferred coding solution doesn't come to play. We've seen instances where manufacturers have waited until a couple of months before their product is launched, and that's simply too late. There's simply not enough time. So it's really important to kind of manage those expectations and give yourself enough time to curate the information that's needed to support the coding application and to work through some of the implications of these coverage, coding, and payment decisions. I reflect a little bit on what's happened recently with some new drugs where the manufacturer has been faced with kind of some what I think of as unexpected coverage decisions. And I can't help but wonder if those companies had done a little more research or spent a little more time thinking about coverage, coding, and reimbursement, if the results or even their own internal strategic planning may have come out a little bit differently.
Yeah, no, that's a fair point. We still work with a number of companies that just did not get coding exactly how they wanted it for launch. Either they did not purchase claims data to understand what that patient journey looks like, or what have you. But not having each code aligned for launch just causes a lot of headaches and just does minimize the access. So no, thank you, John. When we're talking about CMS and reimbursement, site of care obviously has tremendous influence on how it acts, correct, John?
Yeah, absolutely. And particularly in the drug arena, site of care has a significant impact on the way that a physician or a provider is reimbursed for the drugs that she prescribes. In a physician office, that's our traditional buy and bill process where the physician purchases a drug, submits a claim to Medicare for a drug, and gets paid for it at the average sales price plus 6%. That's a traditional fee-for-service payment process. And those payment rates are updated quarterly. So there's a constant sort of flux in terms of the evolution of those prices. By comparison, in the hospital outpatient setting, that's a prospective payment system where payment rates for hospital outpatient encounters are based on historical claims data. Now, payment for drugs is still based on ASP, but under the hospital outpatient prospective payment system, lower cost drug payment is actually packaged into the payment for the overall hospital encounter. So it's important to keep in mind where a particular drug falls in terms of the cost spectrum. And then, of course, with acute care inpatient, in the acute care inpatient setting, this also is a prospective payment based system that uses historical claims data. But in this case, Medicare's severity adjusted diagnosis related groups are used to set payment rates for the inpatient encounter. And for the most part, those bundled payments cover all of the services, including drugs, that are used during the hospital stay. And then last but not least, in the Part D pharmacy benefit world, prices are really negotiated between the PBM or the pharmacy and the manufacturer. The Part D plan pays the pharmacy based on benchmarks. Sometimes it's AWP, sometimes it's WAC, sometimes it's something else. And then payment from beneficiaries is based not only on formulary tiering, where the drug falls in the formulary, is it tier 1, tier 2, tier 3, but also where the beneficiary falls within the overall Part D benefit. Are they in the deductible phase? Are they in the coverage gap or the donut hole?
Sure.
Or are they in the catastrophic phase?
Sure. And John, does Medicare payment influence or have influence on other payers such as Medicaid and commercial plans?
Yeah, we've looked at this quite a bit, and it seems like there is an influence between what Medicare sets as a payment rate and what commercial plans use, but it's really more of an influence in terms of setting a benchmark. What we've seen with a lot of commercial plans is a lot of times they'll take Medicare's ASP and use that as a benchmark for their own payment rates. They'll maybe pay ASP plus 2% or 4 or 6% sometimes, but that ASP becomes the benchmark that they use to have their own negotiations with their own providers.
Yep. No, correct. Well, John, thanks. I appreciate the time. One of the things is pulling this all together, and we've worked with a number of companies to be able to do that, looking at it, the sweet spot from a coverage, coding, and reimbursement perspective. Understanding how CMS makes those coverage decisions and existing coding systems to pay is essential, obviously, to determining how to approach the reimbursement strategy. There's a number of things that we've identified as best practices as we've worked with a number of companies. One is mapping the journey. We mentioned this before, really understanding, what codes are going to be needed by the healthcare provider in now, but also in the future, and identifying what codes you're going to have to spend time to talk to AMA, talk to CMS to make sure you get those codes. Establishing the timing, making sure that, again, you're working your way back from launch, understanding what codes you're going to need to get assigned, and then understanding what that timeline looks like. Again, there are a couple of examples we can give where the client did not, or a company did not have their codes aligned for launch, which obviously is an important time. Identifying the process, right? Really understanding the procedures for each of these strategies, and making sure that you're aligning all the ducks. And then the last one is navigating the systems. Really, how do you approach AMA? How are you approaching CMS? Which obviously, John, you worked at CMS for over 20 years. You're familiar with that process, but it really is a nuanced dance, and we've talked about that before. So for the next upcoming webinar, we'll be talking about navigating through Medicare, what that dance looks like. Again, this is probably the one that I am most interested, especially since we have John, a former Medicare officer, here at the webinar. Very interested to get his take on how to approach Medicare from a how, what, when perspective. And then the last one, to look forward. But I'd like to thank everybody for joining us on the webinar. John, thank you as well. And if you want to connect with us, if you have any questions in the meantime, please feel free to do so. But we'll see you at the next webinar. Take care.
Bye-bye.